Today I'll be chatting with Dr. Nicola Guess about how changing your diet can help you manage type 2 diabetes. This episode is the first of a two-part conversation. We'll be discussing diabetes prevention in part 2. Dr. Guess has been studying diabetes management for over a decade and has directly helped many people living with type 2 diabetes through her private practice. In this episode, Dr. Guess explains why there is no one best diet for type 2 diabetes, only the one that's best for you. She shares some of the latest research on why even modest weight loss can often be clinically meaningful. Last but not least, Dr. Guess shares practical advice for making positive changes to your diet. Dr. Nicola Guess runs a private clinical practice as a registered dietitian focused on diabetes prevention and management. She's also an associate professor at the University of Westminster, a research fellow at King's College London, and head of nutrition research at the Dasman Diabetes Institute in Kuwait. Dr. Nicola Guess holds a PhD in diabetes prevention and a master's in public health and is trained as a registered dietitian. Please note that this conversation should not be seen as personal medical advice and that any major dietary changes should be undertaken in consultation with your healthcare team. Let's dig in. Welcome to Get Real Health. I'm your host, Dr. Chana Davis. This show cuts through the noise to give you science-based insights from real experts so that you can make smart, healthy choices. Welcome to the show, Dr. Nicola Guess. Thank you so much for being here.
A pleasure. Thank you for having me.
So today, as we discussed in advance, we're going to be having kind of a two-part conversation. So I think first we're going to be recording a little chat about diabetes management, and then we'll have a separate conversation about diabetes prevention. We're just setting the stage,
sure.
So people know what to expect. Okay. I have so many questions. I guess I should also say this is, as you know, such a broad topic. You could spend your entire career on this. So we're going to narrow it down mostly to focus on dietary factors in both of those discussions today. But we'll touch on other things as they come up. So let's just get right into it. I usually like to start with some definitions just to orient people. So what actually, is there a very clear definition of type 2 diabetes? What are the current definitions right now?
I mean, diabetes, whether it's type 1 or type 2, they are defined by blood glucose. So our diagnostic criteria are based around blood glucose. So type 2 is slightly different from type 1 because type 2 has two main components. The beta cells of the pancreas that normally secrete insulin stop working properly. The second part is insulin resistance. So the liver and the muscles don't respond to insulin. That's totally distinct from type 1, which is an autoimmune disease.
Mm-hmm. And so can you be explicit about what like the diagnostic criteria look like if you have this number? Like, is it just a single test is sufficient, or you have to monitor over time? At one point in time will tell you all you need to know?
So in general, it's diagnosed based on one test, and that's because people often have symptoms. If people are asymptomatic, often it's twice. And so there are a variety of cutoffs. If your fasting glucose is above 7 millimoles per liter, that's type 2 diabetes. We now use hemoglobin A1C. That's an average measure of your blood glucose over a 3-month period. And if it's 48 or above, that's considered type 2 diabetes. We also have a random, so if you randomly kind of turn up at your GP or in a hospital and it's 11.1 millimoles per liter, again, that could be diagnostic of diabetes.
It's nice that there's a clear, fairly uncontroversial definition that helps simplify things a lot.
I wouldn't say it's uncontroversial, but it's clear. It's set in stone. Yeah.
Okay, but different countries agree. Different countries use the same definition.
Yes. So the challenge comes with when we get down into pre-diabetes, and this is a fair argument that essentially it is a continuum. I mean, there's really no difference between what's going on if it's 6.8 and 7, right? It's just 7 is the cutoff.
Yes. Okay, that makes sense. So one of the questions I also think is useful to think about as we set the stage is it? I've heard people talk about reversing diabetes. So is it truly reversible so that they would basically erase all? I mean, you could bring down those blood glucose measures, but does that actually erase all the risks that you might have had while you were in uncontrolled diabetes?
Great question. And I guess the short answer is we don't know completely how much of the damage you can get rid of or eliminate. The current understanding, particularly if people have had type 2 diabetes for some time, is that there will be some residual damage, whether it's to blood vessels, whether it could even be damage to the eyes and so forth. But remission, I call it remission because I think it's a more accurate, precise term for what's happening, is such a new concept that we actually don't have data. Now, what we do in the UK, if someone gets remission of their type 2 diabetes, they still have to have their checkups. So their eye checkups and so forth. So we do kind of treat them as though they still have type 2. And really that's just protecting their health long term and making sure we prevent any complications.
Yeah, so what are the main complications that people worry about?
So there's the cardiovascular side of things, which can be strokes or heart attacks. You also have microvascular complications. So this is things like neuropathy or retinopathy. And this is essentially damage to the nerves long term, whether the innervation is in the eye, that can affect your eyesight. It could affect your kind of pain, but also sensations in your legs and feet. And this can be a big risk factor for example, getting gangrene. And diabetes is one of the leading causes of amputation because people get an infection. So because their blood flow is affected, because their extremities in many ways are affected, they can get an infection, not realize it because their sensation has been diminished, and the infection can get worse and worse over time and develop into gangrene even before a person can notice or deal with it. So it's a horrible disease. So even though it's common, people kind of think, oh, everyone's got diabetes now. It's actually a very disease to have.
Yeah, that's going to say, I feel like it's in many ways not viewed as super serious because it's so common. So that's why it's useful to think about what matters if you don't control it, as we then sort of segue from there into how can you control it.
Yeah, absolutely.
So as I said, I wanted to focus on the diet aspect of it because I know that that's something you've written about a lot. I'm sure you've researched all aspects of it, but I'm particularly interested in the dietary side of it. So a lot of people are probably wondering which diet is best for diabetes management. Now, I know there's a lot of controversy. There are people in, that are very staunchly advocating one camp or another. So clearly there's going to be a complicated answer. So I think to help unpack the answer, I would find it helpful for you to speak in terms of some of the metrics of what best is and how do you measure the success of a diet. Is it strictly just the blood glucose control, or do you actually measure some of the risk factors for these downstream medical sequelae that you're worried about? Anyways, those are just some of the things percolating in my mind.
Yeah, that is a great question. I loved how you phrased that. Like, can you answer about best in terms of what the outcome is, right? Because often people say the best, something good for the gut microbiome might be awful for blood glucose, for example.
Yes.
So absolutely, we need to consider cardiovascular risk as really the ultimate outcome, because this is what eventually kills people. And so in that sense, many diets can work. But also a thing that I focus on as a dietitian is it kind of gets a bit more complex as well, because cardiovascular disease is influenced by blood glucose, by blood pressure, by LDL cholesterol, and different parts of the diet affect each of those things, right? So let's say you have a ketogenic diet, super low carb, so your blood glucose concentrations are going to be super low. That's fab. You'll probably lose a lot of weight on it, so that's going to help lower your blood pressure, but your LDL cholesterol might go up. Conversely, if you have a ketogenic diet and you could make it super high in monounsaturated and polyunsaturated fats, that could fix a lot of the stuff for you. A whole food plant-based diet, super high fiber, low saturated fat, that has been shown to get remission of type 2 diabetes too without weight loss. So there's lots of things that can work, but those are the things you're focusing on: blood glucose, cholesterol levels, and blood pressure. And obviously weight, because weight drives each of those things.
Yeah, so is there a lot of intersection then between or overlap between the diets that are recommended for optimal cardiovascular health and those that are recommended for optimal diabetes health? Or...
Yes, I would say there are. I've never seen a sensible person in nutrition say have as much saturated fat as you want. All the evidence, and anyone, again, sensible in this space would say, yeah, you want to focus on replacing saturated fat with unsaturated fats. Whether you're going for a high fat or a low fat diet, you should be focusing on the quality of fats. Things like fibers are very useful for many reasons because they improve the gut microbiome. That's linked to type 2 diabetes in many, many subtle ways. It's also linked to vascular function. So that's kind of a good thing. And the great thing about high fiber diets is there's almost no risk. So you're looking at things that can be beneficial, but also things that are kind of a no-brainer. Because, I mean, what harm are you going to do by telling someone to eat nuts, seeds, veggies, and so forth? So yes, those are the crossovers. Where the diets really differ is really this argument about carbs, fats, and to a certain extent proteins, but certainly carbs and fats.
Yeah. So, you know, this I think there's a lot of focus in the diet world in general right now on insulin as, you know, as the key to everything. And so I guess I'm curious your thoughts on to what extent that focus makes sense in the diabetes context. And if it does make sense, how does that not preclude low-fat diets? I mean, how can low-fat diets, which have a lot of carbs in them, still possibly be okay, given that they do drive an insulin response? And I know there's some nuance between, you know, good complex carbs and simple carbs and free sugars and intact sugars. So I wanted you to help unpack all the nuance within the carb category, if you do truly believe that it's not as simple as avoiding carbs.
Yeah, I do actually now. And I say this because we've just recently finished a study and I know of some other data that's also pointing towards this. This assumption we have that lowering carbs is going to lower your insulin, I don't think is as simple as that. But there's another factor here. People always forget about weight. And weight is a huge driver of insulin. So if you lose weight, your fasting and postprandial insulin comes down. If you gain weight, both of them eventually go up. So whatever diet you can consume, if it happens to be a high carb diet because you like that, if you can lose weight on that diet, your insulin will come down as well. I do think we need to figure out how to optimally reduce insulin. And there's work out there that suggests that simply moderately reducing carb, let's say from 50% of calories that most people have to 25 or 30, maybe doesn't have the effect that people think that it does on carbohydrates. Because in a healthy person, your liver doesn't release much glucose at all after you eat, because your liver is super sensitive to insulin, and you basically stop, or the processes of glycogenolysis and gluconeogenesis really stop or shut down after you eat. That probably doesn't happen in type 2 diabetes. So essentially your blood glucose is running high all the time in type 2. This is what our data suggests. So moderate changes in diet don't really affect that. So the idea that by reducing carbs, you're going to automatically lower glucose and therefore automatically lower insulin, I don't think is that simple in type 2. I think you either need ketogenesis, so you need low enough to get ketones up, because ketones suppress hepatic glucose output, or I'm very interested in the role of replacing a lot of carb with protein, because that seems to do the same thing.
What are your thoughts on fasting diets? I know some physicians are saying that that's acceptable for diabetics, and others say, but I need to eat every 3 hours. Meal frequency is so important, that's just not a viable strategy.
I think a lot of this depends on the type of diabetes a person has, whether they take insulin or sulfonylureas, medications that could cause a hypoglycemic event. In general, my view is that fasting, the data has been overinterpreted. People are too excited about fairly poor quality studies. And I think the cardiometabolic effects seem to be driven very much by the timing of fasting. So where you're looking at time-restricted feeding, the early time-restricted feeding where you eat in the morning and not in the afternoon or evening, that is so antisocial. I have had in my career, I have lots of patients on super low carb, keto, paleo, vegetarians, vegans. People can stick to any diet, patients that I've got. I have never had a patient that can stick to early time-restricted feeding. Because, I mean, what do? Like, you want to go to the pub with your friends, you want to go out to dinner, you want to go to the cinema, you just have no social life. So if the cardiometabolic effects are driven by early time restricted feeding and actually maybe worsen with late time restricted feeding, I almost think that's a non-starter. And now obviously that kind of time restricted feeding is something that you do the same pretty much every day. So the idea is that you have this long fasting window and you do the same thing every 24 hours. I think that is still a better approach than the intermittent fasting, where you're maybe fasting on a Monday, eat Tuesday, fast Wednesday, eat Thursday. Simply because so much of glucose homeostasis is driven by circadian rhythms. People take their medications at a given time. They get into a routine of eating certain things. So regularity can be very useful in type 2 diabetes for predicting and controlling your blood glucose concentrations. So I wouldn't recommend the intermittent fasting where you're alternate day fasting to any patients with type 2, except if it was a good way to help them lose weight. And they weren't on any medications really apart from metformin.
Yeah. I've done a lot of looking. Last year, I was spending some time digging into different weight loss strategies and how they compare because there's so much controversy there. And it was interesting to see how consistently weight loss was associated with this glucose control and various sort of cardiometabolic risk factors that any diet on its own would say, look, we improved cardiometabolic risk. And you're like, but every diet can claim that. So it was usually the diets were claiming that their diet provided that unique benefit when really it seems to be a benefit of weight loss.
Oh, absolutely. Yeah, this is the control group, why the control group is so important. Absolutely.
Now, is there a simple explanation for why, and I guess from the weight loss perspective, how much weight loss moves the needle for cardiometabolic risk? And I guess, sorry, that's the question. Like how much matters? And, if you're slightly overweight, are you going to get as much benefit as someone who's much more overweight? And how does that answer depend on your starting point?
I mean, this is a difficult question to answer because it differs so much between people. I mean, as a general rule, the relationship between weight and cardiometabolic risk is linear. And probably if you looked at enough people over time, even if they were losing 2 kilograms, you would see benefit. We even have some type 2 diabetes prevention studies where, over a period of 3 years, people are losing 1.92 kilos, which really isn't much, but that's enough to prevent type 2 diabetes. So any helps. Where I think things are getting more interesting is what we've realized about remission. That there's kind of been this idea that, aim for moderate weight loss, 5% weight loss is going to help lower your blood glucose. And for sure it does, because there's that linear relationship. There does seem to be a cutoff point, there a threshold to get remission. So the moderate 5% weight loss doesn't seem to do that much to help someone come off their medications and get durable remission for type 2, whereas that seems to be say a 10 kilogram cutoff or maybe 10% of body weight. And that I think is pretty interesting, that I wouldn't say that relationship is necessarily linear. I think there's clearly some kind of physiological threshold people meet where they get normalization of beta cell function, for example.
So you define remission as not needing medications, or how is it defined?
There's no international consensus on what a definition is, but for me, a good one is definitely having a blood glucose level not in the diabetic range and being off medication for at least 2 months. The bariatric surgery literature often uses more strict definitions where it's having had normal blood glucose for 2 years and not been on medications for 2 years. So, that's, you're really getting into, they've had remission for a long time. I think an important thing to note here is whether it's normal blood glucose, as in normal glycemia, or pre-diabetic blood glucose, because currently the definition allows for pre-diabetes. So they would say you've got remission even if you've got pre-diabetes, as long as you're not on meds. And I think we need to be careful about that, because when people have pre-diabetic levels of glucose, they still have impaired beta cell function and a lot of insulin resistance. And so it kind of suggests if you're only getting to that range, you haven't fixed everything underneath that could be fixed.
So I want to start shifting into making this, putting this into practice for people. So if the answer seems to be according to our conversation and some of the other literature that I've been digging up, that, there are multiple dietary strategies that work. The ones that allow you to lose a bit of weight are probably going to be more effective. That's one of the biggest drivers through which they work. So, how do people put this into practice? Losing weight, we know, is not easy. So how do people figure out which one? I guess one thing is also, how do you figure out which one's going to work for you? Is it just about a personal fit, or is there anything else that helps people figure out which one's going to be the diet that works best for them?
I mean, in my practice, I have the luxury of being very individual with things. And often I will talk with the patient about the literature and what it shows, and try to understand their goals. Because if a person's goal is, I want to get off my meds, I want to get rid of type 2 diabetes, then you need more dramatic options. And I would talk through that and what it would take. And very often for me, the two really good options are low carb and high protein. Combining the two, I think, is important. Probably keto as well. So keto's kind of different to low carb, high protein, because you want moderate protein, but much lower carb. And then the kind of meal replacement approach. And so what I would do is I have meal plans drawn out, pictures of meals, examples, and so forth. And I would talk with the patient about how these diets work, how long they would need to stick to it for. For example, so with the meal replacement, you can go back onto your normal diet after about 2 to 3 months, for example, and that might be beneficial to some people, whereas others, like a food approach, so something like low carb, might be better. So with remission, I do that.
Sorry to interrupt, but I don't know. I'm not familiar with the meal replacement strategy. What is that?
Oh, sure. So this was a big trial called the Direct Remission Trial that came out in 2017. And it was done in primary care, so it's really applied. So it's not like a clinical, really intense research study. It was delivered by nurses and dietitians within primary care, and they used meal replacements, so shakes and soups, for a period of 2 to 4 months. And the aim was to get them to lose 15 kilograms of weight loss. And the reason they were aiming for that kind of threshold is because they did modeling from gastric banding. So this is where this isn't the bypass, this is where you have a band just around the stomach. And where that threshold of weight loss was achieved, that increased a person's chance of getting remission substantially. So they kind of said to themselves, the investigators, let's do a dietary study and aim for that 15 kilogram weight loss. And so they pretty much achieved it. They got to about 13, 14 kilograms, losing weight over 2 to 4 months. Then they transitioned to normal food intake. They had lots of support and maintained their weight at 1 year. And so that was the study.
One very method question. Did they replace every meal with, or?
Yeah. Okay. Yeah, for 2 to 4 months. Yes, more or less. I mean, you could get someone to lose 15 kilograms if you did, 750 calories a day for maybe 6 weeks, depending what their starting weight is. This in this study, some people did it, I think, that quickly, but they had quite a pragmatic approach because they wanted people to stick to it. So if people had a wedding or maybe had something challenging happening in their life and they were like, I just want to go back to food for a couple of days, they had that flexibility. So it was mostly meal replacement, but some people took, I think, 4 months to get to their target weight.
But it's basically an ultra low calorie diet on the order of 800 calories a day, and you make it easy to achieve that by providing the food, or and that covers all your bases nutritionally in the same time. Yeah,
so they have to be nutritionally complete because you're following these diets for such a long time. So that means all vitamins and minerals are supplied. And one thing I would note, lots of people hear this and they think, oh my God, shakes and soups and nothing else for 2-3 months. Are you kidding me? Patients actually love it. And people also think, oh, there's no way you could survive on 800 calories. You would just feel terrible. Actually, the opposite is true. What happens is we think it's probably partly ketosis, that you can actually feel terrible in the first couple of days as you adjust to it. Once your body gets into ketosis, that your energy restriction is so great, and obviously your carbohydrate intake is so low, you start to oxidize fat as a primary fuel source, and you generate ketones. That gives people, it seems to, a bunch of energy, mental clarity. They feel fantastic. And then, of course, for many people, the weight's coming off so quickly, they love it. And it gives them a period of food and maybe bad behaviors or unhealthy behaviors they've adopted over time, so that then you can kind of start again when you're
Yeah.
transitioning to food.
Yeah, I have a friend who was doing something similar for her church every January, and she was speaking of the increased mental clarity that she was experiencing, and sort of surprising energy as well.
Yeah, exactly. The hard bit comes when you've got to transition to food.
Yeah. I wanted to wrap up pretty soon and move on to the prevention side of things. But any, I guess, last practical tips for people, it just can feel overwhelming to how to get started and how to prioritize maybe the most impactful changes you can make.
So what I hand out to patients and I use a lot is a plate planner. So it's basically a circle which represents a plate, and I focus on proportions of food. And I always, with every patient, whether it's vegan, vegetarian, or animal protein, is focused on getting maybe a quarter, maybe a third of the plate from protein always. And then often I recommend that they replace the starches, so that's the things like potatoes and rice, with lentils or chickpeas, so go the pulses route. And so I focus on changing proportions, and it always involves lowering starch and always involves increasing protein.
Okay, well, that's helpful. Yeah, I also find meal plating to be a really good strategy for just making sure you're staying balanced and thinking about what you eat, right?
And not doing too much maths. I mean, I don't think people want to weigh stuff out. So I kind of say, okay, what would you normally have? And if they have like a spaghetti bolognese and it's half a plate of spaghetti, maybe 2 tablespoons of veg, I say, okay, have half a plate of veg and 2 tablespoons of spaghetti.
Yeah. Well, thank you very much for this fascinating conversation about diabetes management. Is there anything in this field that people can look forward to that's coming in the next few years in terms of, obviously we don't have every question answered. So is there anything that you're particularly looking forward to in terms of tools or information and unanswered questions that people can look forward to?
Yeah, I think there are 2 things. I think the first thing, and I'm doing a lot of this research myself, is looking at more weight neutral ways to get control of type 2 diabetes. As the population is getting older, people develop type 2 at a lower weight. I have many patients who are 75 years old. They want to get remission, but they don't want to lose 10 kilograms. And I think we'll get more data showing that there are ways that we can do that. And maybe not without any weight loss, but maybe we can get remission with 3 to 4 kilograms weight loss. I think that's exciting. I think the second thing is we're going to learn more about how beta cells can come back to life. What we've assumed for a long time is as you develop type 2, your beta cells basically break. They no longer work properly and you can't get them back. I think we'll see more in that space in the sense that we can hopefully reverse a bit more of the pathophysiology of type 2.
Well, thank you very much for this fascinating conversation. If people want to learn more about you and your work, what's the best place to learn more?
So I'm very active on Twitter. So my name, if that's what you call it, is Dr.
Your handle?
Oh, handle, thank you. I'm so old. Dr. __ Guess, so 2 underscores. That tends to be more sciencey. I interact with a lot of other academics on Twitter. I'm also on Instagram with the same handle, and it's a lot more patient friendly. So I give tips, talk about recent studies that have come out, and try to put things into lay terminology.